So thank you for inviting me to give me this opportunity to talk about first-line treatment of ovarian cancer. I don't have any conflicts to declare. In this talk, what I want to do is really explore the options available for the frontline management of this disease. And in many cases, I think there is differing points of view, and there isn't a hard and fast answer to what we should be doing. And I think the important thing is to come away with the tools to think about how we manage this disease and how we best communicate and give options to our patients. Sadly, all of us are very familiar with this journey for the patient, with approximately 2/3 of our patients presenting with symptoms and later stage disease. Decisions have to take place about the timing of surgery, systemic treatment, and in subsets of patients, maintenance. But in line with the GOC mandate, and I don't know if this is coming up well, I think as part of the frontline treatment, critical we get in with that germline testing for patients, high-grade serous, and as was alluded to this morning, we don't forget about other potential patients who might benefit from referral for genetic screening, so supporting the GOC mandate. Are all cancers the same? Oh, I don't know quite what happened with that one. I had great slides on there and they seem to have disappeared, but I mean, we've been living with this at meetings for the last 2 or 3 years, that instead of just being a rare cancer, ovarian cancer is, of course, ovarious. Now I have a new word. And that each of the histologic subtypes have different evolutions and a different course and respond differently to frontline treatment. Had my slides come up, I was going to say that we also, at this point, are we at a point where we can shift away? There we go. We've been hearing this recurring theme, but are we ready to shift our frontline management? Are we ready for a prime time shift to different frontline managements for each histologic group? I'm not sure we're there yet, but as later in the talk, I'm just going to touch on this subject. So who gets systemic therapy and when? We talk a lot about those later stage patients, but around 20% of women with ovarian cancer will present with stage 1 or early stage 2 disease. And for the trainees in the group, I thought I would just take a historical trip about the evolution of chemotherapy usage in this subgroup of patients. There have been a number of studies, but perhaps the most famous of these are the ICON-1 trial, back in the days when it was carboplatin or nothing, which looked at early stage cancers. The challenge with that study is that those patients weren't staged, so it's a study looking at the benefit on unstaged patients. And the ACTION trial, which looked at either cis or carboplatin alone or in combination, in cancers that we weren't sure if they should receive chemotherapy or not. Overall, the study reported an improvement in survival, but they were unstaged patients, and questions remain about which patients in those early stages should be getting treatment. There have been a series of systematic reviews, including by our own L'Oreal, and 2 Cochrane reviews, of which this is the most recent. The conclusion is still that early stage cancers potentially benefit from adjuvant treatments, but we've got a lot of questions that remain about whether all early stage cancers need treatment. So I'm just going to ask in the room, if you have a stage 1A, optimally staged, high-grade serous cancer, how many of you are giving them chemotherapy in the adjuvant setting? Okay. We know those patients can have, from retrospective data and data from others, around 25 to 30% risk of recurrence. But if I was to ask you the same question about, say, a stage 1B, optimally staged, lower grade cancer, I know some people don't use grade 2, how many of you would be giving chemotherapy in that setting? Okay, so it is a mixture, and we don't have a lot of data to support it. I know some guidelines, like the NICE guidelines, suggest that we shouldn't be giving adjuvant chemotherapy to grade 1 or 2, if you include that stage 1A or 1B tumors. And I think what you've got to balance is the data that we have available with the potential toxicities and the discussion with the individual woman. And later on, we'll argue about whether any grade 1 cancer should be really getting adjuvant chemotherapy, or whether we should be thinking about different approaches. So this slide came into the deck after a series of emails about 6 weeks ago between various members of cancer centers across the country. And the ask to us was, in a patient who is found incidentally to have a stick lesion, precursor lesion for high-grade serous cancer, should that person receive adjuvant chemotherapy? We know from the literature that they have about a 4.5% risk of later developing peritoneal carcinomatosis. So do we know anything about adjuvant chemotherapy in this population? Before I tell you the results of the emails and the literature, is anyone giving adjuvant chemotherapy for women with stick lesions? Okay. So this is a controversial area, and there's also the controversy about staging, whether it's cytology positive or whether you look at that. But I have to say the Ask the Experts emails was in the guideline if there's in the region that if there is no frankly invasive cancer, that we actually like the data to recommend giving chemotherapy. So on that poll of people, that the views were, and the literature tends to be, the jury is out, and that we should not be giving adjuvant chemo. Having said that, I think this is an area that needs watching and is something for the future. And again, discussion with the patient, critical when we have areas where we're lacking data. So maybe a little bit less controversial for a medical oncologist at least. Neoadjuvant chemotherapy. Historically, it was those with poor performance status, extensive disease. But after the publication of the EORTC trial and then the CHORUS study, which showed reduced perioperative morbidity, length of stay in hospital, and equivalent survival outcomes, there was increased uptake in the use of neoadjuvant chemo. It's estimated in the US now that around 40% of women are receiving neoadjuvant chemotherapy. There have been 2 further other studies confirming that benefit around the perioperative stage, but they have not produced the survival data to see how this compares. Now, I'm not going to go into what is quite an extensive discussion. It's not a talk on neoadjuvant chemotherapy. But I was interested to see that the SGO and ASCO have produced a practice guideline in 2016, and I think their advice is reasonable, and that is if neoadjuvant chemotherapy is going to be contemplated, you need a histologic diagnosis, preferably from a core biopsy, CT scan, and most critically, a discussion with a GYN oncologist, and I'm preaching to the choir here. Decisions then center around whether a patient can be optimally cytoreduced, whether they have significant comorbidities, and ultimately as well about the patient's perspective and how they want to approach their disease. I think critical, I don't know if there are any medical oncologists in the audience, so I'll talk on the numbers of trainees, but all of these women need to be evaluated by a GYN oncologist. I do not ever want to see what happened to one of my colleagues in the not too distant past, have a woman come in who'd had carboplatin, paclitaxel, and bevacizumab, was on maintenance bevacizumab, and was then sent in for an opinion on surgery, having had a response. Should be 3 to 4 cycles, and there's relief there, because I'm a medical oncologist. I don't have to get into the fight as to whether neoadjuvant versus primary debulking surgery, but I know, having recently witnessed the talk that Dr. May gave at the My Goals meeting, it can get heated, but I'll leave you guys to fight that out over coffee later. So what's systemic treatment? The GCIG consensus in 2004 recommended carboplatin paclitaxel every 3 weeks as the comparator arm, and we had GCIG consensus 2015, said every 3 weeks carboplatin paclitaxel. So all of you who are now having a postprandial nap, or the Toronto contingent that need to go to a meeting, now's the time to go. But it was with a but. Many of you, and I'm going to take a straw poll at the end of this, are very aware of the data on dose-dense chemotherapy. This is the Japanese study, carboplatin AUC6, day 1. given either with paclitaxel on day 1 or with a dose-dense regimen of 80 milligrams per meter squared, day 1, 8, 15 of IV paclitaxel. And what that study showed was an improvement in the median progression-free survival, which was statistically significant for the dose-dense regimen. Later data showed in terms of overall survival that benefit was predominantly seen in those that had suboptimal or cytoreduction, so greater than 1 centimeter disease. It was less obvious and not statistically significant in those with optimal cytoreductive surgery. We then had GOG 262, which was the North American study to address this issue, and that trial looked at the 3-weekly carboplatin paclitaxel with bevacizumab being optional, and this study always reminds me that we are very fortunate sometimes to practice medicine in a public healthcare system. And the dose-dense regimen, very similar to the Japanese study, again with optional bevacizumab. What we saw in the US at the time, post 218 and ICON 7, was that around 80% of women, together with their oncologists, opted for bevacizumab in their treatment. And a reminder about the fact that dose-dense and 3-weekly have slightly different side effect profiles, with higher rates of sensory neuropathy in the dose-dense regimen and maybe slightly higher rates of neutropenia in the every 3 weeks. So again, in discussions with patients and thinking about this, many factors come into play, such as the convenience for the patient, such as the toxicity profile, such as underlying maybe comorbid factors coming into their treatment schedule. What, of course, we saw in this trial was that there was no difference in the overall patient population in terms of progression-free survival, so different to the Japanese study. For those choosing bevacizumab, there was no difference, but for that small number of women who did not receive bevacizumab, there did appear to be an advantage to the weekly regimen. Small subgroup analysis. And of course, that Japanese study had suggested that it may be those with macroscopic disease that might particularly benefit. They're also, of course, in the angiogenic studies, the ones that benefit from anti-angiogenic agents. But sadly, we're not going to get any further information on this from 262 because there's subgroups and then there's subgroups of subgroups from which we can make sense. So what I just want to ask in the room, I'm going to ask 4 questions. Four groups. One is who gives solely every 3 weeks carboplatin paclitaxel. Secondly, who gives the dose-dense regimen to all patients. And then the third question is who kind of does one sometimes and maybe gives it to those bulky, suboptimally debulked or neoadjuvant patients, but then gives 3 weekly at other times. So first of all, who gives every 3 weekly carboplatin paclitaxel as kind of their standard regimen? Okay. Who gives dose-dense as their standard regimen? And who kind of gives a hybrid? Sometimes they give dose-dense, sometimes they give others. So the good news is everyone's right, because we don't know the answer at this point. But I think this is one of those times where you look at the data, you think about your patient population, and you have a conversation until we have better data. As a reminder, there are other dose-dense regimens out there, and I just picked this study. This is a MITO study that looked at carboplatin paclitaxel. I draw your attention to the 60 milligrams per meter squared of paclitaxel in this, so slightly lower than was used in the Japanese study, but this has carboplatin every week as well. Progression-free survival was similar. In this trial, though, it had quite a good toxicity profile, and so, you know, an interesting question centers around that as well in terms of patient choice and benefit. I think what we're all, well, I'm waiting for, maybe everyone else has fallen asleep, is the results of ICON 8A, though, which is going to provide us with some greater clarity over dose-dense versus every 3 weekly regimens, and ICON 8B, which is considering adding in the effect of bevacizumab. So there are some trials out there going to come up that may give us greater clarity in terms of how we finesse the delivery of carbotaxel, but at this point it is very much patient choice. These slides are, my next slide is going to appear largely from a comment from Dr. Hal Hurte. That, by the way, is not Dr. Hal Hurte. I thought it was, I thought it was more of a Paul Hoskins kind of stance, but I get to go first. It's good. But just as a reminder to people that sometimes patients have issues with paclitaxel, and back in the mists of time, we did a whole bunch of trials combining carboplatin with a variety of other agents, whether it was gemcitabine, there were studies with Calyx, there was studies with topotecan, and these all kind of had equivalent efficacy. So there are other alternatives, exploring different funding models that could be thought about for patients. Angiogenesis inhibitors. So we're all familiar with the ICON-7 study, carbotaxol every 3 weeks compared to carboplatin paclitaxel with bevacizumab continued for 12 months after completion. For the high-risk subgroup, and this is a very particular subgroup, so suboptimally debulked stage 4 patients, we know from that study that there was an improvement in overall survival, and that the intriguing question arose that those curves start to come together after the bevacizumab is stopped after the 12 months. So there are unanswered questions about the delivery, many unanswered questions about how we use bevacizumab, one of which centers around the duration in the frontline setting, and many people get into conversations about what to do about neoadjuvant patients because these were not included in ICON-7 or I believe in GOG 218, the other trial. ROSIER was a phase 3b study which was pretty permissive and was designed to look at different, the longer duration of treatment, not a randomized trial, but the bevacizumab was delivered for a longer period of time. And as you can see, it was in different combinations of carboplatin Taxol, so very permissive for patients entered into it. It was a phase 3b, as I alluded to, single arm, 1,000 patients. They could receive up to 36 months of bevacizumab. Progression-free survival was 25.5 overall, and for that high-risk population, 18.3. Around 20% of these patients had had neoadjuvant chemotherapy. And if we look at that on the curves, what we see is that for the high-risk group, as we alluded to, 18.3 months. The non-high-risk group is actually quite interesting. It's 32 months, which if you take the single arms of ICON-7 or 218 is actually longer than you would have seen in those studies with anti-angiogenics. But the challenge with ROSIER is it isn't a randomized trial, and we're going to need the AGO study to kind of answer that in terms of duration of bevacizumab. And the other aspect is the measurements for tumor measurements were at different time intervals, so there may be some bias with that. But I think there's some interesting data there that suggests that that duration of bevacizumab may be a factor. Now, for most of us, bevacizumab's funded for 12 months, and I guess we're going to be watching that space as to whether, with increased data out there, it should be funded for longer. But again, this is a maintenance phase, so quality of life in our patients. What happened in terms of toxicity in this study? Well, the rates of hypertension and proteinuria were higher. Median time for hypertension was about 2 months, but around 20% of those women developed grade 3 hypertension, who developed hypertension, developed it over 12 months. So, you know, you need monitoring. Again, those come with health risks as well. And obviously, it's more trips into hospital and considering it. So I think as we move on, we're going to have to think about the placement of bevacizumab. Now, that question about neoadjuvant patients, so they were fine in this trial. They didn't have specific toxicity issues. Again, practical questions that come up certainly in my practice, and I know in others. You have a patient not suitable for surgery, maybe a stage 4 patient or a stage 3C. Do you give them bevacizumab up front, because it's hard often to know that a patient won't be a surgical candidate, or do you wait until they've had neoadjuvant chemotherapy to do the surgery? ROSIER, the patients got bevacizumab after they'd had surgery with neoadjuvant, and anecdotally, and I know that's not a great data to go off, but I think if you, my view, and I know the Gynae Drug Advisory Group at CCO have wrestled with this, is that it can be challenging if you give that up front for those 2 or 3 cycles and then have surgery. I've treated GI cancers a lot, and patients seem to get into more trouble if you try and give bevacizumab in that setting. So my personal anecdotal thoughts, and I have my bias, is that if you really think, and for most of us we think women will be a candidate for surgery, is give them just straightforward carbotaxol and then think about the bevacizumab afterwards if they're suboptimally debulked at that time. So, and anyone who wants to, I'm happy to hear any other alternative because we don't know the answer, but that would be my thoughts. So the longest running saga in gynae history, I'm going to move on to now. Yes, I'm going to talk about endometrial cancer and lymph nodes, because that's what you want to do, is hear a medical oncologist talk about that. Human evolution? No. IP chemotherapy. You knew it was going to come up if it was either me or Deanne here. So, other group of patients, the stage 3 optimally cytoreduced group of patients. We had a bunch of trials leading up to 2016 that had positive results, with one of the key ingredients being 100 milligrams per meter squared of IP cisplatin. We had the Cochrane review, and we later had long-term follow-up on 2 of those critical trials, 114 and 172. And clearly GOC was at the lead in setting standards for IP chemotherapy and implementing that in Canada. We had real-world data from Alexi Wright, and they showed a benefit, even though 43% of patients got a non-standard chemotherapy regimen. And those included dose reduced to 75 milligrams per meter squared that later appeared on the NCN guidelines, and also IP carboplatin. So all good. We even potentially had a biomarker there, fairly crude, but low BRC1 expression by immunohistochemistry on the 172. I draw your attention to that median overall survival, 84.1 for patients getting IP 1 months. If you remember back at that GCIG slide that I showed, it was around 35 months. So that's pretty stunning data to me. But there is always an elephant in the room, a heavy elephant. GOG 252, presented by Joan Walker at SGO 2016. This was a trial, the next generation of IP chemotherapy trials, trying to incorporate dose-dense paclitaxel. Use of IP chemo, acknowledging that 100 milligrams per meter squared was really not tolerable for most patients, and in 172 only the median number of cycles delivered was 3. So they used IP 75 milligrams per meter squared, and like us at CCTG, looked at carboplatin, and of course bevacizumab. So I alluded to the trial design, carboplatin paclitaxel with a dose-dense regimen, carboplatin IP, but with an IV paclitaxel in the dose-dense regimen, and then cisplatin with paclitaxel day 1, 75 milligrams per meter squared, and an IP dose on day 8, so it's a kind of modified Armstrong protocol. What happened was, it was pretty toxic at times, so hypertensive rates in the IP cisplatin arm for grade 3, that's high. And there was also sensory neuropathy. And as many of you are aware, the progression-free survival for the optimal stage 2-3 patients was actually no difference. And in fact, those median survivals, PFS, are quite low. So what did GOG 252 teach us? Well, there was a lot of dose reductions because of the toxicity, which was probably added to by the bevacizumab. So a third of the patients in the IP cisplatin arm crossed over. There was 15%, I think, of the IP carboplatin crossed over. Interestingly, around 70%, only 70% of those patients were high-grade serous histology. And if you think about it, the patients most likely to benefit may be that group when you look at that BRCA picture. So did that cloud the analysis, the histology of the patients? And of course, bevacizumab. However, it remains, it's a negative IP study as it stands at the moment. So, seeing the 252 data, I just wanted to ask the room, first of all, who was doing IP chemotherapy before 252 was presented last year? Can I get a show of hands? Could you take your hands down if the 252 data influenced you to decide to stop doing IP? Okay, I still think there is a question there. I think the regimen, I think what we do know is don't give bevacizumab with it. And I think, which is fortunate because we're not funded for it. But I think we have to see more data on that, especially the breakdown on that high-grade serous group and the overall survival. So what about neoadjuvant patients? Well, our very own OV21 Petrox study presented last year. That, by the way, at the bottom is what Deanne and I are going to have on our tombstones for the years we worked on OV21 Petrox. But as you know, it was a study that randomized patients at the time of surgery to either IV, and we balanced our arms for day 1 and day 8, so not a traditional IV regimen, but containing IP cisplatin with IP paclitaxel and IP carboplatin with IP paclitaxel. So we looked to try in the first stage to identify which of those 2 IP arms might move forward into what was at the time planned to be a phase 3 trial. Draw your attention to the fact that over 90% of these patients were high-grade serous, maybe not a surprise in a neoadjuvant population where you were seeing response, but perhaps this is a group that's more prone, if you believe the earlier data, to benefiting from IP chemo. And again, intriguingly, if you look at the patient population, it's not too similar to that included in the Chorus and Vergote study, if you think what stage they were when they started out. This was well tolerated, but of course 3 cycles of treatment, and we didn't have too many issues there. And as many of you know, at the end of the first stage, the IP cisplatin at 75 milligrams per meter squared, not the 100 milligrams per meter squared in those prior upfront positive studies, did not meet the barrier for being better than the IV arm. It was not greater than 5% better. What we did see, because unfortunately, as you know, we had to truncate the study, when you compared IP carboplatin with IV carboplatin paclitaxel-based regimens, was an 18.9% benefit in the per protocol group and a slightly lower rate in the intention to treat. Obviously, 9-month PD is not a standard endpoint, but our IV arm did perform in the ballpark of the historical data we used to calculate this. It wasn't anymore, because it had to be a smaller trial, powered to detect a difference in overall survival. But I'm going to throw out some intriguing numbers to you. If you look at the median overall survival for the IP carboplatin arm, and if you think about it, if you were thinking it in the context of, say, the Vergote study or the Chorus study, you'd add on about another 2.5 months for the 3 cycles or 3 or 4 cycles of pre-op chemo and then the time to surgery. That brings you up at conservatively around 62 months. There was in the appendix the median overall survival with confidence intervals for the microscopic in both Chorus and the Vergote study. Our IV arm is in that ballpark because the median survival in their best prognostic group was about 45 months. Interestingly, and I'm now going to make Deanne weep, the upper limit of the confidence intervals for the best group, the microscopic group, is actually lower than this would be. It's about 55 months, 54 months in the Vergote study. And this, remember, is both microscopic and 1 centimeters. To me, that raises an intriguing question that if we carried on this study, would it in fact have been positive, just based on that data? So what did we learn, apart from the fact that Deanne and I have now taken years off our life? Well, we learned that the IP carboplatin and IV-IP paclitaxel was well tolerated, and I think it adds to the literature of people that were selecting to use IP carboplatin based on retrospective data. Certainly it was safer, and I think that it is least at good. Now, does that mean that in the clinic that we're offering it as the option? It's challenging without overall survival data. I think that the data of 252 and OV21 makes it hard to say that we should be giving 75 milligrams per meter squared of IP cisplatin to our patient in the outset, given that there is no randomized trial data to support that, even though it's on the guidelines. And I accept from 100 it needs reducing. I still don't think we've addressed the day 8 paclitaxel issue, and I'm just touching on the subject of HIPEC, as that sometimes comes up with our patients. That's heated IP chemotherapy at the time of surgery. Having been involved in running that program here for colorectal cancer patients, for a number of years. I don't see how that is ever going to be feasible on large scale for ovarian cancer patients. It's got a high morbidity, and I don't see that it's materially going to give better outcomes compared to IP chemo. There are small studies with it, but I kind of try and be very honest with patients, because I've had a few that have asked to go to the US for opinions with regard to that. So IP, unresolved issues, of course the elephant in the room, but it raises some questions. You know, we certainly can't combine it with an anti-angiogenic, but I suspect you know where I'm going with this. If you are BRCA, you have IP chemotherapy, and then you go on a PARP inhibitor. What does that look like in terms of survival? It's intriguing. We have to follow the biology, and I'd encourage you all to come to the Correlative Sciences workshop, because we collected tissues on these patients. Tomorrow morning at 8 o'clock, I think, we're going to be talking around that at CCTG with Anne-Marie and Mark, and I think we could get some interesting data around who benefited. And clearly there are other things we can deliver into the abdominal cavity. And of course, as I said, the big question of all is IP dead, or is it going to be resurrected? I think we just watch this space to find out over the years. So very quickly, a couple more issues that I think we should touch on. Clearly not all ovarian cancers or ovarious are high-grade serous, and some of them aren't. Low-grade serous is an interesting one. We touched on which early stage, but also the later stage should get chemotherapy. Guidelines suggest chemo, but we know that even in the recurrent setting, response rates can be low. This was presented by Gershenson at ASCO last year, retrospective data looking at after platinum-based chemo, which was their frontline treatment for low-grade serous, surveillance versus hormonal maintenance. And intriguing data suggested an improvement for those ladies who received hormonal treatment. So hypothesis generating, but again, come to CCTG because we'll be discussing the idea of adjuvant in this patient population. Again, hands up in the audience. Who actually gives chemotherapy to low-grade serous in the adjuvant setting? Maybe I'll make it easier and say stage 3, optimally cytoreduced. Who gives them chemotherapy? Who gives adjuvant hormonal data? Adjuvant hormones? Okay. Who gives both to them, hormones and chemo? Again, I think it's an important topic, and if we can avoid toxicity for people, it will be good. Clear cell ovarian cancer, we had some excellent data from Dr. Hoskins published in the JCO, raising the question of whether adjuvant radiotherapy could be considered. And again, the idea of doing a randomized trial is a very intriguing possibility, probably needs to be across the groups, and I would strongly encourage you to come and listen to Anna Tinker tomorrow at CCTG talking about a proposal to follow on from Paul's excellent data. We thought at the beginning, and I'm just going to touch on this, what about giving anti-angiogenics to clear cells? Well, as far as the data that came out of ICON 7, it doesn't look like in the frontline setting that that's particularly helpful. But clearly, biologic therapy in the frontline setting is very attractive for cancers other than just high-grade serous. Mucinous cancers, again, a tough area. And I have to say, I struggle with these guys. You know, are they, you know, what do we do with them? Carbotaxol doesn't work well. And sadly, the frontline trial that might have answered that question, otherwise known as MEOC, which looked at GI-based chemotherapy regimens with or without bevacizumab, had to shut due to lack of accrual. And it highlights the difficulty when dealing with a very rare cancer, and it's something we need to think about how we address. In the future, PARP inhibitors, we saw great data on SOLO2 at the recent meeting, and this is recurrent disease, obviously, but what about those frontline trials? Where are those leading us for high-grade serous ladies? And immunotherapy, excellent talks this morning. Maybe not so promising for all subtypes of ovarian cancer, but follow the science and let's see where we go. Finally, we have to select patients better for trials. We've seen from work with other PARP inhibitors in recurrent disease that looking for signatures not just about BRCA is critical to maximizing our opportunities. Again, hopefully there are going to be opportunities in the frontline setting. We've seen studies that suggest there might be different groups that respond better to angiogenics, and somehow we've got to put all of this together into a personalized format for our patients to make decisions. And this is just a study we did with pharmacogenomics, so it's not just about the tissue. Sometimes it might be about the blood might be about factors to do with the patient predicting resistance. So lots of work, and I just selected on those as points. So back to that point I made earlier about, does one size fit all? Well, kind of at the moment, but I think that hopefully whoever gives this talk in 5 years will be giving a different story, and in 10 years you'll have a talk dedicated to clear cell frontline treatment and low-grade, high-grade and I won't be able to cram it all in. And I did promise I was going to talk over the top of Paul and Hal, so maybe I've succeeded, I don't know. But there's so much coming up, and we've heard about that this morning, but at the end of this, we have to keep the patient first and foremost in our minds. We've got to get well-tolerated treatments that maximize quality of life. It's not good, it's not enough that we develop these new therapies. They've got to be therapies that work for women. Thank you.
Yes, we have time for a few questions. I guess there's one question I would like to ask, and that is, how do you treat patients with advanced mucinous tumors of the ovary yourself?
So I think that's a tough one, and I don't think we always know how to do that. In Ontario, we've had mucinous tumors classified as rare cancers, so you can actually apply for GI-based chemotherapy regimens for those, and that's something that I consider. I know Anna and Jessica were looking at having a registry to look at those, and I do check for HER2 status sometimes in patients as well to look for alternatives, and ultimately I do trials, but I first of all make sure that it really is a mucinous of ovary, because often those are derived from other areas so that they've had appropriate scopes. So we don't have the best answer to that, but I think conventional wisdom of giving them carbotaxol, I don't know that it works for those patients.
So I nominate that you do the talk in 5 years, because you've always done the talk and you do a great job. So I'm not going to lay you off the hook, though, when it comes to the stick. So stick in a BRCA mutation carrier, I think doing nothing isn't acceptable. So chemotherapy, it might be a stretch, but the option of further staging, because these are typically going to be done by generalists. Because if you say to the patient, the stick might be a tiger, and the tiger is loose in your home, and if it is a tiger, it's going to eat you at some point, the patient's going to say, I want you to do something more, and that'll be chemotherapy if you offer them chemotherapy. And you might laugh, but it's not like complex atypical hyperplasia, because if you leave that alone, that lady might get a grade 1. It's not CIN3, because that'll take a long time to turn into a cancer. It's a cancer it's a potential cancer that when you find it, that patient is likely going to die of their disease.
I'm going to throw it back at you as you stood up there. So. Yeah. If you get risk-reducing surgery, what further staging do you think you need to do for that patient? Because again, that's controversial. If their cytology is negative, if their cytology is positive, because I mean, in many of the series, it hasn't shown any further disease or evidence elsewhere. So again. Yeah.
I mean, I think it depends on who did that surgery initially, right? So what's your faith that that person actually took a good look around, has experience dealing with BRCA mutation carriers? But I would advocate for at least a generous mental biopsy, some washings. I probably wouldn't do a pelvic and aortic lymphadenectomy because of morbidity.
So again, back on that, if all of that is negative, including the cytology, would you still have I mean, it's all about conversation, and we can read these things.
Well, I would say I would sort of contract with the patient that that's where we're going to end it, and that we're not going to give chemotherapy, because if chemotherapy is still on the table, then I'm just going to give her chemotherapy, and I'm not going to do those things.
I don't know what the answer is. I think it's a conversation, and you're completely right. I'm not saying that somebody is wrong for choosing to do that, and clearly if you look at the retrospective data, that people are giving chemotherapy, but I don't think we have the definitive answer in identifying those patients or how to move, what we do. And I think it's equally valid to do that and have a conversation and say, look, there's a 4.5% risk that this could appear. And I have a 30-year-old that has peritoneal carcinomatosis, and I have a 70-year-old, both of which had stick lesions in the past. And I don't know we know the answer, but I think it's an important conversation to have with women.
Any other questions? Oh, great. Thank you very much.